we go again. Phase one, we don't have exactly how many days will last, usually from 1 to 5 days. And in the beginning, we have bleeding. So the initial part of the inflammatory phase, as we remember, it's the bleeding. That should stop usually in 8 minutes. That's the most, but it could last the secondary bleeding for 30 minutes. And you will have a spontaneous bleeding during the first 24 hours. So when you do an extraction, you always need to tell your patient that you will have some bleeding for 24 hours after the clot stabilizes and dry itself. Then after the bleeding, we have the hemostasis, which will, in a primary hemostasis that we see, will be a vasoconstriction phase. And then we'll have the platelets plug. The platelets will go together and make a plug, as we remember that. And then we have the formation of the clot, but the clot factors, and that's the end of the hemostasis. After that, we have the breaking of the blood clot by the fibrinolysis. And that's kind of like the phase where the blood clot gets dissolved. After that, we have a phase that we have vasodilatation. Why? We need the blood to come to the area, bringing the cells we have talked about, neutrophils and macrophages, and the production of the different tissue to repair the wound. So we have vasoconstriction in the beginning. Yes. Changing like crazy. Can you check that? It's not changing. Okay, let's see again. Okay, where is it? No, did they close? Cancelar. Where is it? What? Okay, did it close? Is there still in? Is the weird? Doesn't allow me to get in. Now that I left. I hate this technology thing. Where is it? Gosh. No, okay, there he is. Okay. right? Okay, yeah, I know what I should do. Okay, I should do. Gosh, where are you? Yeah, okay, but it works here, but not in the screen. God, where is it? I don't understand why it always like takes me out. Okay, yeah, okay. So we're going in here. Okay, so what I was telling the rest of the class was that we need to remember the three phases: the inflammatory phase, the fibroblastic or proliferative phase, maduration or remodeling phase, and the things we're going to see after we take a tooth out. We will have the marginal gum, the periodontal ligament that will be tear, the cortical bone in white, and the spongy bone in pink. The blood vessels, even though there's mainly one, we usually have 2 or 3 secondary vessels that give the nutrition to the bone, to the tooth. Now, first phase we went through already, the inflammatory phase from day 1 to day 5. We'll start with the bleeding. We should stop in the first 8 minutes around so, and we usually get them or ask them to bite a gauze for 30 to 45 minutes. But we'll have some leftovers of bleeding that will probably last 24 hours, so we need to make sure to tell the patient and remembering to tell the patient that specific thing. And after we have that, we have vasoconstriction phase, which allowed the tissue not to lose blood. We got the primary and secondary hemostasis. And after that, we need blood. So after we got stabilization with the blood clot, it will get dissolved by the work of the fibrinolysis. We'll have the vasodilatation phase. We already went through, bring the macrophagus out the neutrophils to take the tissue that is dead and the bacteria of any contamination in the area. Now, after the day number 3, we'll start to be produced the granulomatoid tissue, mainly produced by the fibroblasts. So we'll have some production of the collagen and the fibrinoid production in the area. We'll have the blood that is going to get more dry and will be replaced with some production of the fibroblasts. And we also will have the production and the activation of the capillary vessels that go from the bone through the area, making sure the tissue that is going to be repaired has enough blood energy and cells to be protected then. Now, so the end of the inflammatory phase starts with the appearance of the fibroblastic and the early production of the proteins who will be remodeling the tissue, making the granulomatoid tissue. But now, in the proliferative phase of the phase led by the fibroblasts, we have like 2 activities mainly. We have the fibroblastic activities and the endothelial activities. In the base of the alveolus, we will have the fibroblasts will be producing the new tissue. So you will see in the borders of the wound will have more production, and it will kind of like start to turning white with the production of the fibroblasts in the borders of the cortical bone. As well, in the area that it's in the endothelium, we'll have the production of that, and they will try to grow and touch each other. One of the things that we usually don't want, that tissue goes down and takes some of the tissue off the bone. So that usually we want to avoid. Let's see if we can have a line that can be seen. So what we don't want is a tissue to go like this, because we want to have the best quality of bone. We want to have good quality of endothelium too, but if for implants, for example, we want to make sure the bone is as thicker as it can get. So for that, it's the reason we want most of the times to put a graft in here, so we can help the endothelium to have a primary healing, plus we'll make sure that the bone it's a little bit higher. So that's the reason we put grafts in patients that we want to put an implant later on. Why is that? Because the endothelium tissue grows quicker than the maturation of bone. So always the endothelium is going to win the bone. Okay, so we'll have the two phases, fibroblastic area and the endothelium, who are independent from each other, okay? Now, we'll see the endothelium is growing. It's getting close together, and we'll have the yellow will show that the connective tissue, it's been growing from the borders thanks to the fibroblast activity. So you'll see, as in the secondary healing, the healing goes from the borders and from the bottom to the top. Now, at the end of the proliferative phase, we'll have all the tissue that it's covered by the granulatoid tissue, and we'll have the first appearance of something we haven't seen before, the osteoblasts. Okay, so we need to remember that the last days of this phase will become a more fibrotic tissue, and even though we start with a lot of fibrin, in these phases we'll have the collagen that will change. Remember, we have the collagen 1 and the collagen 4 who intervene in the process of the first steps and the maturative phase. So in here, at the latest part, the osteoblasts will appear. Something good to point it out, we already have a healing of the endothelium that is complete. Now, this is more like a graphic. This is usually not true. We usually get a little bit more down, and this will be like the perfect healing for us. But if we don't put a graph, that's hardly a true thing to become. So we'll have the granulatoid. I hate this. Okay, thank you, computer. I don't hate you. Okay, so we enter then to the maturative phase or the remodeling phase. So we'll have something called a primary callus. Will be there after 10 days of the extraction. So what that means, we will have replace the granulomatosis tissue will be replaced by an immature bone. Will be called an osteoid structure produced by the osteoblasts. So that's change between the soft tissue and the bone healing. around day 10, we have the osteoblasts who start changing the matrix of the fibroblasts, will be repaired by the bone healing, making an osteoid structure. So the fibrous tissue will be disappearing. So we see the white one will be what was made by the fibroblasts. It's continuously being replaced by the work of the osteoblasts. So that keeps growing, and something that you have seen that is really interesting is you start losing the borders of what you had in here. See if I can maybe use something like this to show you. Okay, so you had a clear border of the cortical bone and the rest of the granulomatoid tissue, and that's gone already. So this border, it's gone. It's growing to the center, and this border starts to become a little less clear. So we'll see, we're going back to the first one, and we see really clear the difference between in here, the cortical bone, and the bleeding. So that's going to being reduced and changed and disappearing. So after 4 weeks, we already have a callus formation. Now, some books there say 3 weeks, some books say 4 weeks. That's not an agreement complete. So you will see some books have a primary callus formation after 3 weeks, another say after 4 weeks. So a primary one. And when that starts, it depends of if it's a primary or a secondary bone healing. But if we have a secondary one, the production of the bone will start at day 10. And we'll have a complete cover of bone and immature bone at 3 weeks to 4 weeks. After that, you will have a losing. You will have the tissue that the border start to being lost. So the limits between the alveolar cortical bone start to get lost, and the maturation of the bone goes more and more and more. What is that? Is the synthetics of the minerals. So all the organic extraction of the bone, it's already done by the week 3 to week 4. But after that, we have the mineralization of that. That could takes, it depends of what bone we see, but some people say 3 months, some people say 6 months. So in between of that, we'll take the maturation phase, who the bone will be exactly as the other bone was. So for implant treatment, we usually recommend 4 months. That is the time when the bone is enough mature. But in 6 months, the bone is considered to be mature with the same disposition of minerals to the bone. So something extra that you see is that here you're been losing the borders, but you have still seen a difference between this in here and this in here. So after 6 months, all the extraction looks the same, and you cannot see where the tooth was. So that's interesting to see. So for implant purpose, we usually wait 4 months to put the implant. In normal conditions, if the patient has some other conditions, has bad healing, we usually wait 6 months. But 4 months is kind of like the gold standard for that. Now, we have systemic conditions that make a risk of infection and a risk of the healing that could not go very well. So we have a nutrition, we have advanced age, we have metabolic diseases, we have a circulatory status, and we have the glucocorticoid and drugs that are directly involved to the wound healing. We're going to talk about some of them in here. Well, maybe not. So we already talked about nutrition. We need to have good oxygen in good levels by the red blood cells. We want to have smart and fast leukocytes who can get to the site and being able to eat all the material who has died from the process of extraction. We always get bone that it's affected who dies, ligament tissues that dies, and borders of the gum who dies. So that needs to be eaten, would be probably the better word, eaten by our system, so it doesn't become dead tissue who gets involved in the healing. Advanced age goes through many things. Less blood in the area of healing, less activity of cell defense production, so you have an immune system that is not as well, and the synthetic of different fibers of collagen and fibrin, it's also reduced. Metabolic diseases could affect any of the healing process. The circulatory status, for example, for people who smoke, will make less available the blood. Remember, in the healing process, we have a first step that we want vasoconstriction. So we get the hemostasis, but after that we want vasodilatation. So the blood comes with nutrients and cells to protect and help repairing. And the glucocorticoids and drugs usually affects the normal reaction of the tissue. So if we have glucocorticoids in our system, that will make us less fungible in the repair, because we have given orders to our body to not defend well because of the corticoids. That's the reason when we give corticoids to a patient, we want to make sure it helps them in the first phase of healing, of inflammation, but we also need to remember that they will affect how the repair system works. Okay, now we saw the systemic factors, and now we're going to the local factors. The local factors, we are going to, even though they're almost kind of like the same, we're going to break them down in 4. A strange body, necrotic tissue, ischemia, and wound stress. Now, the strange body. Anything that it's between the borders of the wound will affect the wound healing because it will get in the way, and it will make a chronic inflammation reaction to that. So when we have something that shouldn't be there, we will be produced an chronic inflammation and a reaction of the bacteria. Now, if the thing that it's in there, it's a bacteria nutrient, so it helps the bacteria to eat and reproduce, it will have a bacterial proliferation and will make an infection. Okay, so we have the strange body. One who gets in the way of healing physically and produce a chronic inflammatory reaction that will make dirt and suture material as well. If we leave too much time, it will get in the way of healing as well, the suture material of the filament as well. And the bacteria who will be there to contaminate the area. It needs a great amount, we'll get an infection. If it's a small amount and we have a good conditions for that to reproduce, we'll get an infection as well. The second, the necrotic tissue. So if we have a lot of tissue bone of gum that has died, the cells will not be able to take it out and it will get in the way of the repairing. So when I'm saying that the macrophagus and the neutrophils eat the tissue that is dead, I'm talking about tissue that cannot be seen by the eye. So a small tissue who are not an eye-seeing tissue. Because if you see a tissue that it's close to die or no survive, or bone that has not an attachment of muscles or periosteal is lost, it's better to take out that tissue. It's better to take out that gum that is not going to survive, or that bone that it's loose as well. So those things need to be taken out so the process can be healed. So you need to guarantee the site you're working on that the tissue that is left is in good conditions and will be able to survive. Now, it's better to be more aggressive and take out the tissue that you think that is going to die or not going to survive, that leave it there, because you leave it there, it usually get in the way. But we always balance things, because we don't want to take too much tissue that we make a bigger socket. We'll have a difficult thing of the secondary healing process. So everything always needs to be a balance. Now, the ischemia is always something important as the wound stress. So the ischemia will be present if you have a bad anesthetic technique, principal if you do that in the palate, and if you have a stress wound. So the other thing that is clear, it's the importance of choosing your filament. One of the things that we're usually advised for filaments is the filament doesn't need to be too strong, or it will break the tissue, or it will stress the tissue. So it's always only going to want to do, only you want to do is to put the tissue together, so it could be a healing process correctly. So the other thing that is important is to try to remove the suture. When you choose a suture, that should be taken out at the correct time. If you do it too early, you will break the tissue and the borders will be loose. And if you do it too late, it will become a strange body and will get infected. Now, to finish up, we're going to talk a little bit of what we say about the ischemia. This will be a factor that will produce the tissue to not heal correctly and maybe turn to a necrotic tissue. So the tissue could die for that. So what happens if we have an ischemia in our tissue? First, we don't have enough antibiotics. We'll get there. So that's the other tissue that is important. So if the wound doesn't have good blood coming through, it's not only the blood who comes, but all the things who make sure the bacteria doesn't grow, and that's the antibiotic too. The oxygen and the nutrients, so the tissue can repair, is affected. Antibodies that comes through and help out in the defense of our system too. Which are the motives of that? We always want to make sure we don't have a tight suture. We have a bad flap design that in the process of doing the suture, we see that it's not long enough, and we replace and make a different wound. External pressure of the wound as well. Internal pressure, and usually internal pressure, it's the normal inflammation that the tissue produces. So then you need to remember another property of the filament is that when we have the inflammation and the tissue grows, the filament needs to have the capacity of stretch itself And then when the inflammation goes down, it needs to go back to the same sites. So it doesn't make the tissue loose. Hypotension will affect our healing process as well. The vascular disease, anemia, and diabetics too, for the things we talk about of the need of nutrients of our tissue. Okay, so with that we can complete the topic about healing. Now we have some, I think, confusion or doubts about some topic that you need to explain, Mr. President. Okay, what's the deal? What's the problem? Yeah, okay, we can change.